Hello, and thank you for joining our e-seminar today, Balance e-seminar SOT, MCT, and ADT test interpretations. We're delighted to have JonPeters join us as our presenter. I'd like to tell you a little bit about Mr. Peters. John earned his PhD from Simon Fraser University in British Columbia as part of a series of clinical and research studies focused on changes in brain electrical activity and human behavior. John joined Neurocom in 1988 to work with Lou Nasher on the clinical and research applications of computerized dynamic posturography, including the development of InVision, head-shake sensory organization, and postural evoked response protocols. John retired as the Vice President and General Manager of Neurocom in 2012. Without further delay, I'd like to turn the presentation over to John. John?
Thank you, Teresa. So we can start off with the very first slide here. And the objectives for this afternoon, I'm going to try to keep this very simple, give you an overview of the background of the test, and base it off of the dynamic model of balance control. We're going to try to take that balance model apart and test each aspect of it, then put all that back together to describe how that information can help you in the overall management of a patient. It's very critical to understand that everyone's approach to postural and balance control in terms of assessment and rehabilitation is really a matter of their perspectives that they started with from coming out of school. Not to say that those are wrong, they're all very well founded, but they need to look at a very broad spectrum of balance control and assessment. And the reason for that is that balance is a very miraculous and complex and interactive process. It's not something that you think about on a day-to-day basis. It's subconscious, and it should stay there, but once it becomes a problem, that is, you lose balance control, then it invades and can become a significant cognitive process. The dynamic model that we're going to look at was put together originally by Lou Nasher, and it's an engineering systems model which allows you to look at the sensory aspects and the motor aspects of balance control. So on the sensory side, you have environmental information coming in through the visual, vestibular, and somatosensory systems. The central nervous system in the brain compares, selects, and combines that information to determine where the body is in space. On that basis, a series of motor movements are selected, either automatically or voluntarily, if it's an self-initiated movement, to set up a series of muscle contractile patterns, ankles, thighs, and trunk muscles to move the body, and the process continuously repeats it. So if you look at balance control in this manner, it's very easy to see how you can split it in half. You can look at the sensory side of the problem, and you can look at the motor side of the problem. On the sensory side, you can look at system inputs. You can look at the integration of that information. You can look at body position. On the motor output side, you can look at whether it's a voluntary movement, an automatic movement, what muscle structures are involved, and how effectively the body is moved in space. You can then put this model back together to very successfully understand what's going on in a patient's balance control issues. So let's start first with just the sensory side. The environmental interaction is what you deal with every day. Somatosensory system has to take on surface changes, irregularities, base of support changes. Your visual system is constantly dealing with movement of either yourself or the environment, and it's very critical that you be able to distinguish these two from each other. A lot of patients with balance problems cannot make that distinction. The vestibular system, of course, is very responsive to gravity and is also responsible for keeping eye movement focused on the objects and in space. All of that is integrated into a system so that if you want to do something such as approach an escalator, which is in motion, So you need to narrow up your base of support to approach that and time the step so that you get on there correctly. In order to do that, the brain has to reweigh all of the sensory systems, because at one point you need more visual input, what is out there. You need more vestibular once you're in motion on the escalator, and you need some out of sensation to tell you that you've landed on that step correctly. The estimation of the body position in space is very critical, and that is frequently referred to as center of gravity alignment. This tells you whether or not the person is standing straight up and down, leaning too far to the left, as in this graphic, too far to the right, too far anteriorly, or too far posteriorly. And it can be seen in some patients that balance problems are simply due to extremely poor center of gravity alignment. This is not uncommon in the elderly who, for one reason or another, have developed a significant fear of falling over backwards. So what they do is they lean too far forwards. When you lean too far forwards, your center of gravity moves out in front of your feet. You start to develop a shuffling gait, and you become very unstable and extremely likely to fall down. In addition to that, you will find that the elderly who may have at some point fallen or know somebody who has fallen will artificially close up that center of gravity, so that instead of being able to move over a broad range called the limits of stability, they artificially close it, and if they move 1 or 2 degrees, feel like they're about to fall over. So all of this has to be tied together before the brain can tell the body what it needs to do in terms of making an appropriate motor movement. And obviously, once that is initiated, the movement is selected, the activation of the muscles has to take place correctly. They have to be scaled appropriately so as to not over move the body. If you're pushed or you're jostled, do your muscles respond with the appropriate amount of force and the appropriate timing, or do they over-respond and toss you completely off balance on their own? The outputs then can be either reflexive or voluntary, and in this case, we're only going to look at the reflexive motor movements. The voluntary motor movements are addressed in a separate lecture where we're looking at things like the limits of stability, rhythmical weight shift, step up and over, assessment protocols, and so on. Here, we'll be looking strictly at the automatic and adaptive postural responses. Other factors that affect balance assessment and management, one of the most critical is cognitive status, learning, attention, memory, and judgment. These are very critical elements that have to be taken into account in any balance assessment. Attention and memory have come to play major roles in recent years as researchers and clinicians have recognized that a lot of patients with balance problems, when you first assess them, have some of the similar characteristics to patients with minor head trauma. Also in the elderly with balance problems, once they have to focus their cognitive abilities on maintaining their balance, they can appear to have short-term memory deficits, such that when your grandmother walks from the kitchen to the dining room, she may spend so much cognitive processing power on just the act of walking there, she may forget why she went there in the first place. What appears to be a short-term memory problem, when in fact it is just a cognitive processing issue because all of her attention is focused on making sure she doesn't fall over. Emotional tone, anxiety, depression, fear is obviously there. Pain most certainly is going to play a role. And then, of course, the non-physiologic motivation, secondary gain, and so on. The literature clearly shows that computerized dynamic posturography has a major role to play, not in just classic real balance problems, but in ferreting out those issues that are related to non-physiological or secondary gain. About 93 to 95% accuracy rate in identifying patients who are faking or exacerbating a balance problem on their own. So which patients are appropriate for testing? Any individual with a functional activity limitation resulting from sensory or motor system impairments, whether you know or don't know what the pathology is. And this latter part is very critical because this is a systems approach to balance control. We're not trying to focus in and say that the patient has a left vestibular deficit or a right vestibular deficit specifically. What we want to know is whether or not the vestibular system as a unit is being used by the brain correctly. There are situations where you can have a perfectly normal functional vestibular system and the brain will choose not to use that information, and therefore the patient can have what would appear to be a vestibular-based problem in the absence of any pathology. And of course, you want people who have the ability to learn motor skills, or more importantly, perhaps relearn motor skills, because that's all part of the rehabilitation program. So what is the best test for balance? Clearly, from what we've said so far, no one single test is going to pull out all of these pieces. You need specific protocols to address each one of those sections and then be able to assemble that data back into a conclusive whole. So we're going to look, as I said initially, at the sensory side. We're going to do this with the sensory organization test protocol, which allows us to isolate out visual, vestibular, and somatosensory input into the central nervous system, and then say what the relative contributions of each of those are to the patient's balance control. The sensory organization test is a series of 6 conditions where the patient starts standing on a stable surface with their eyes open, so vision is good, the surface is stable, no sensory systems are disadvantaged, and in this situation, the classic approach is that the somatosensory system is the dominant sense maintaining balance control. The second test is the absence of vision or eyes closed. Again, the surface is stable. No vision is present, so the patient has to rely more and more on somatosensory input to balance. You should recognize this as the classic Romberg approach to balance control assessment. The third condition now is where things become interesting. In the third condition, the visual surround is unstable. That is, it is sway referenced to the patient's center of gravity. If the patient doesn't move, the visual surround does not move. But every time the patient moves, let's say forwards, leans forwards a degree or backwards a degree in standard sway, because everyone has a little bit of sway, that visual surround will follow them. So the surface is stable, vision is not reliable, and the somatosensory system again is used. The easiest way to think about this is very similar to when you're sitting on a stoplight in your car and a large truck or a bus moves next to you, and you get the sudden sensation that you're in motion, but you as a normal individual can suppress that information and say, I'm not moving because my somatosensory system and vestibular system tell me I'm not moving, therefore I know the outside world is moving. There's a significant population of patients with balance problems who cannot make that distinction, and they have what is known as a vision preference balance problem. They trust visual information more than vestibular or somatosensory, and so they cannot separate movement of the self from movement of the outside environment. It's not an uncommon thing to find in whiplash cases. That's why a lot of people who have one whiplash seem for some reason to get a second one at another stoplight. They don't know whether they're moving or not. The fourth condition now, the visual environment is stable, that is a reliable source of information, and the surface is unstable or sway referenced. So now the floor of the platform moves in conjunction with the center of gravity of the patient. So if the center of gravity moves anteriorly a degree, the floor will dip a degree or a quarter of a degree. It's a continuous relationship so that somatosensory information, which is from the feet, the ankles, and the lower limbs, is ineffective or inappropriate for the movement and control of balance. So the patient needs to use vision and vestibular input. The fifth condition, the eyes are closed, the floor is sway referenced, so both somatosensory and vision are out of the picture, and now you're putting maximum stress on the vestibular system for the maintenance of balance control. And in the sixth and most difficult condition, both the visual environment and the floor are sway referenced, so now somatosensory and vision are again unstable or disadvantaged, and the vestibular system is maximally challenged for the assessment and control of that patient's balance. The data then looks very similar to the chart you see here, where the top line in each case is the anterior-posterior body sway of the patient. The second line is a shear force tracing that tells you how much horizontal force the patient's feet are generating on the floor as they attempt to balance themselves. And we'll discuss that aspect of it a little bit later when we talk about looking at ankle versus hip balance strategy. You can see that when a patient is very stable, there's minimal body sway, which is exactly what you would expect on the first three conditions, which are really fairly simple. Then there should be very little shear force on that second trace. As the task becomes more and more difficult, the body sway picks up, then there's more shear force being generated by the patient. In this case, the patient actually had experienced a free fall where they lost balance control very quickly on the first trial of condition 5. Here on the second trial of condition 6, there was also a fall reaction. What we want to know then from these data, the raw data, is what is the quality of the sway? You expect it to be relatively random, and if you do see rhythmic or oscillatory sway, then that is a red flag for a possible aphysiological assessment. Typically, stability increases over trials within each condition. There's a very minimal learning effect, but not enough to drive the data from normal to abnormal, abnormal to normal. You also want to be aware of whether or not the harness is being too tight. There's very strange or unusual body movements, or a flag for a problem with the force plate itself. In order to calculate the data for the sensory organization test, we calculate something called an equilibrium score. The anterior-posterior body sway of the patient over the course of that 20-second trial is searched by an algorithm to find the maximum posterior to maximum anterior movement. That distance is then compared to the total theoretical limits of how far a normal person can move and not lose their balance, which is 12.5 degrees. That mathematical relationship then is turned into the equilibrium score, where a very high score of 100 would be like a pillar of stone. And that's very seldom, if ever, seen even on the very easiest conditions. As the number goes down, stability decreases to the point where the patient actually loses balance and experiences a fall reaction. Mathematically, the formula is very straightforward. So then we can graph this data in a variety of different ways to tell us a lot of things about that patient. The first thing you want to understand is that this gray region back here is the 95th percentile confidence limits for an age-matched normal population. So for the scores on any given test, to be normal, they must exceed that 95th percentile cutoff, and in a sense, they would then show up as a green bar, as this individual showed on conditions 1 and 2. If the scores are below the 95th percentile, then they will show up as red, differentiated here in pink just to show you the difference between the two bars. Nominally, this would be seen as a red set of bars as well. If the patient exhibits a series of fall reactions, then the label fall shows up on this graphic right here. It's critical to notice whether or not the data follow the same general trend as the normative data in the background. Here you see that as the tasks become more and more difficult, the scores get lower and lower and lower, even in normal people. If you see the reverse trend, that is, the patient shows you very poor scores on the easy trials and normal scores on the bad, difficult trials, that's an instant sign that you should be looking for an aphysiological data set. Once you've looked at the overall pattern of the data, the composite score will give you a very quick index of whether or not overall the data is or is not within normal limits. In this case, obviously it's not, because these fall reactions are counted in here as zeros and drops the composite score. That can have a significant amount of information in terms of whether or not you're looking for meaningful improvement or the possibility of risks for falls. That data can then be further subdivided into a sensory analysis, a strategy analysis, and center of gravity alignment, which we will discuss individually in a moment. The sensory analysis is intended to be a simple way to let the reader know what the relative contribution of the somatosensory, vision, vestibular, and vision preferences are in the management of this patient's balance control. These are very simple ratios, and if you use only the sensory analysis to interpret this data, you could easily misinterpret this data as often as you would interpret it correctly. They're only there as a guide to help in a discussion of this data set. They're not intended to be the final critical answer. And that is because these are, as I said, simple ratios. The somatosensory is the ratio of condition 1 over condition 2, the classic Romberg quotient. So if it's red, then the patient is not effectively using input from the somatosensory system to maintain balance. And this is where I want to point out the reason I say you can be wrong in interpreting this data. If both of these conditions resulted in abnormal equilibrium scores, let's say that instead of being very high like these, they were very low but relatively equal down here, then obviously this ratio is going to come out to be very high, close to 1. So the ratio would be normal, but the equilibrium scores, the raw data, would be abnormal. So you have to look at that information from the top down. What's the raw data look like? What do the equilibrium scores look like? And then you can start talking about whether or not the somatosensory system was being used effectively, the visual system was being used effectively, the vestibular system was being used effectively, or the patient had what's known as a vision preference balance problem. A lot of patients have vision preference balance problems. That is conditions 3 and 6, where the visual surround is in motion, results in poorer performance than when the patient has their eyes closed. It's very common for vestibular patients to develop vision preference problems, and that's been referred to in the literature as the classic 3-5-6 pattern, and we'll see one of those in a minute. The strategy analysis is very critical because when patients balance and normals balance themselves, The more stable you are, the more you should move about your ankles to maintain your balance control. That is, you don't need any large, fast hip-type movements to regain balance control that if you would if somebody really gave you a strong shove or you slipped on a piece of ice or something. As your balance decreases, you should, however, invoke more and more of a hip movement in order to maintain your balance. So normal balance control, these graphics, the scores, the equilibrium score and the strategy score for each test should fall within this basic parallelogram. And that tells you that the patient uses the appropriate amount of balance or the appropriate type of balance for the degree of stability. So it runs from a total hip strategy to a total ankle strategy, from a fall up to being stable. An ankle dominant strategy is commonly seen in vestibular cases. That is, they lose balance so quickly that they simply fall over like a tree blowing over in a big windstorm. So their data points, particularly on trials 5 and 6, and possibly on 3, will be down on this baseline down here. It's an inappropriate strategy, and if you put this patient through a course of vestibular rehabilitation and did not try to include into that any training relative to improving their hip strategy to get them off from an ankle dominant balance strategy, you've really only solved half of the problem. So you do need to make sure that hip strategy and muscle structures are involved and possible lifestyle modifications to help these patients out. A hip dominant strategy, on the other hand, is one where when the patient is reasonably well balanced, they're executing far too much hip activity in order to maintain that. This is common in the elderly. They have a little ankle weakness, a little bit of peripheral sensory loss, perhaps some peripheral diabetic neuropathy, and it's a very big issue with trunk instability and pain. When anytime they're on an icy or a wet surface, they're going to have a balance problem. So if you have an elderly person who has developed a fear of falling over backwards, so now they lean too far forwards, and they have a hip-dominant balance strategy, you have a patient who has a biomechanical-based balance problem. Their sensory systems could be functioning perfectly well. They're complaining of having a balance problem. They do have one, but it's a biomechanical in origin. So you need to take these pieces and put them all together to look at that puzzle. And the center of gravity is a critical one as part of that. As I was saying with the elderly, they frequently will have a tendency to lean far too into the anterior because they're afraid of falling over backwards. A lot of vestibular patients will have a bias to either the left or the right side, which can, in some cases, tie into the side of a peripheral deficit, but that data set, to my knowledge, has not been totally supported. It's critical, however, to know this, because if you have a patient with a vestibular loss, vestibular system deficit, and they have a severe balance COG alignment problem, if you don't move that center of gravity alignment into the center before you start the balance retraining exercises, then all of your balance retraining exercises are being done off balance. You're actually working against yourself as you try to help this patient along. So you need to work from the outside in. You take care of the simple things, put them in place, then move further up the system. So here's a simple raw data case example. This is generated, you see in this case a lot of relatively high frequency shear force in the bottom here with not a lot of sway going on. This is this sort of quivering response, which has been can be loosely thought of as quivering, is seen frequently in people with peripheral neuropathy, some central tremor, or ataxia. These kinds of patients need to be referred on for more advanced examinations by neurology, audiology, rehab, and physiatry, perhaps. The second piece of the SOT raw data that's very critical is the simple XY plot. The majority of the time you will see the sway in the anterior-posterior dimension. If, on the other hand, you start to see this wrapping out into like a bow tie arrangement, like I'm drawing out here, then you've got another example of what's going on in an aphysiological case. People will frequently rotate or oscillate in a circular motion because that way they can exhibit a tremendous amount of sway without putting themselves at any great risk of falling down. So let's take a look at a case. Here we have someone who has perfectly normal scores on conditions 1, 2, and 3 relative to the normative data set, but they fell on conditions 4, 5, and 6. So this is demonstrating ineffective use of visual and vestibular cues for the maintenance of balance. This is commonly referred to as a somatosensory dependent balance problem, and the composite score is low as would be expected. That's in contrast to a patient who has a vision dependence balance problem. This patient, if they have good, reliable, stable vision, can maintain balance control even on an unstable support surface. But as soon as you take vision away from them or confound that visual information with a sway referencing, they develop a significant balance issue. So it's a significantly different pattern than one of somatosensory dependence, but there's different sensory systems involved, but the patients have an over-reliance on that particular pattern. This is a visual preference pattern, which is different from a vision-dependent pattern. Now the patient is being disturbed by, or their balance is being disrupted by, inappropriate visual information. So if they have good vision, or they have no vision, they have good vision on a sway reference surface, and even if they have no vision on a sway reference surface, they can still result in a significant balance problem. This is a vision preference. The patient is overly reliant on the visual system for balance control. They can't differentiate whether they're moving or the external world is moving. The classic vestibular case, or the 5-6 pattern, is the patient who has problems only on conditions 5 and 6. In this case, the patient did not exhibit full fall reactions. This is what you would expect to see as vestibular rehab progresses in these patients. Their alignment is getting better, their overall balance strategy is getting better, and their scores on conditions 5 and 6 are improving significantly. And eventually you would expect this to reach a normal limit. Sometimes you will run into cases where the patient will have falls only on condition 5. This is the so-called vestibular 5 pattern. This is a relatively rare problem, but you can see it in a couple of situations. One, where someone is improving over the course of vestibular rehab, and 6 can return before 5. But if 5 stays down like this, then you're dealing with a significantly different issue. And this has been reported in the literature to be associated with space-occupying lesions, but the number of cases is relatively rare in those studies. So it is it's a real pattern. It does exist, but it is a rare one. So what are some of the key findings in the literature? Well, SOT5 scores correlate with abnormal utricular function, as measured by subjective visual vertigo, and SOT5 changes correlate with changes in ADL structure, particularly over the course of vestibular rehabilitation. So you can use the test not only to tell you what sensory systems or systems are involved in a patient's sensory balance loss. You can use that information to show recovery over the course of rehab. You can use that information to determine whether the patient has good center of gravity alignment or not, and whether or not the patient uses good balance control strategies. So you can complete the picture, and as you work your way through the rehab program, all of those scores should show continuous improvement. Let's move then on to the motor side. And what we're going to look at is, as I said, the reflexive side of this equation. What we want to do is be able to challenge the motor system so that we can see whether or not the lower motor structures respond fast enough and with sufficient enough force to rebalance the patient. And we're going to do this now by keeping the platform horizontal, but by jerking it back and forth underneath the patient's feet. This has all of the good qualities of somebody trying to pull a rug out from underneath you. Another analog of that is the classic push test that is used in neurology and in physical therapy, where you push the patient at the sternum and see how quickly and whether or not they can or cannot recover balance control. We do this with 3 different levels, or different sizes of translations, referred to as small, medium, and large, which the small being just at threshold. So a lot of people, particularly those that are skiers, may not even notice that the platform moved, and we don't score that data. The medium and the large movements, however, are definitely at above threshold, and the large one is above threshold for saturation of that reflex system. The responses we're interested in is whether or not the left and the right legs respond equally, both in terms of time and in terms of strength. They should be very close to each other unless one leg is weighted more than the other or the patient has some type of neuropathy impacting the system. This is very critical information when you're looking at the sensory organization test, because if you have someone, for example, who has abnormal scores on conditions 1 and 2, which is the simple quiet standing, you would expect that they would have abnormal scores on a motor control test. And if they don't, then you need to go back and try to figure out why that score was abnormal on conditions 1 and 2. Because if they can't balance themselves in a challenged environment, if they can balance themselves in a challenged environment, why can't they balance themselves in quiet standing? It's also very important in terms of the outcome for prognosis in rehab, because it will show you the impact of very subtle, almost subclinical, in some cases very subclinical changes as a result of peripheral neuropathies. It's equally important in the medical legal world, because the sensory organization test and motor control test together is what gives you the maximum hit rate in identifying aphysiologic balance problems. And in terms of disability and return to work, if you have a patient who has, in addition to a vestibular, for example, based problem, maybe they were in an accident on the job where they may also have sustained a lower limb injury, such as a sprained ankle or a damaged knee, is that limb being effectively used to maintain balance? The motor control test interpretation, again, is done basically automatically, but you need, again, to review that data just as you would review it when you're looking at the sensory organization test raw data. You want to know whether or not the scores are solid and the responses are reliable. The system will give you a confidence score which we'll see in a minute, and those are determined whether you want to go back and do manual analysis. So those of you who are familiar with evoked response studies, such as auditory brainstem responses or visual evoked responses, can easily relate to the data from a motor control test. Here we have the pre-stimulus baseline. At this arrow, we have the onset of the translation of the platform. So this is a shear force tracing. This shows you the platform being jerked backwards. Here it's being jerked forwards underneath the patient. There's a short delay, and then you have an onset of the response of the left leg and the onset of the response of the right leg for both responses. And this is the total body movement. The response should be a nice, smooth waveform that settles back to a baseline fairly stable in a very short period of time. And what we want to know is whether or not that onset latency is fast enough and the amplitude of that response is big enough to effectively rebalance the individual. So here is the complete examination. Each movement is repeated 3 times. That's why you see 3 waveforms here on each of these for the small, the medium, and the large translations. And just like in an evoked response study, the bigger or the more powerful the stimulus, the shorter the latency becomes, and the bigger the response becomes. And you can see that these waveforms automatically dovetail back to a nice stable baseline in a normal or even in pathological cases. If this is not the pattern that you see, but rather you see very wild gyrations out in here, those are typically voluntary responses being thrown in by the patient to help convince you that they have a bad balance response. If you do need to score the data by hand, that is available to you on the system, and simply by moving a cursor across the screen, you can reposition what you believe to be the onset of the waveform. This is a summary graphics for a set of a motor control test. This is for the backward movements on the left here, and this is for the forward movements on the right. At the top of the screen, you see something called weight symmetry. So this is for the small, the medium, and the large translation. And the white region in here, as on all SOT graphics, is the normative data range. So for scores to be normal on any test on computerized dynamic posturography, the scores have to be in the white range. We want to know whether or not the patient bore weight equally on the left and right legs during the motor control test. Because if you have a significant weight asymmetry, the weighted leg may respond faster and with more force than the unweighted leg. This also ties directly back to the center of gravity alignment you saw in the sensory organization test. If on a COG, on the SOT exam, the patient was leaning heavily to the left, but now suddenly they're well positioned and centered, what changed? Nothing should have changed. If they're weighted to the left on the SOT, they should be weighted to the left here. If they're weighted to the right, they should be weighted to the right here. So you need to relate this back to the SOT just as a quick sanity check that the data is consistent with itself. Here we have the onset latencies for the left and the right legs, for the medium and large movements. And here for the left and the right legs, medium and large, for forward movements and backwards. The cutoff or the normal zone here. So these green bars tell you that the latencies were sufficiently fast to effectively rebalance this individual. The little number you see in here is a confidence index. And you would like to see this number in 2, 3, or 4. That tells you you have nice, clean data that's relatively noise-free. Even if it's a 1, if the score is normal, that's good. If it's a 1 and the score is abnormal, I would repeat that particular aspect of the test or consider marking the data by hand. The amplitude is how big that response is at any given time for the small, medium, and large. Again, the data should be symmetrical, and it should be within this white region. So the larger the stimulus, the bigger the response. The larger the stimulus, the shorter the latency. So it follows all of the same rules. The composite in the middle of the screen right here, then, is a numerical weighted average of all of these scores. So even if you had one of these that was slightly out, then as long as the composite overall is within normal limits, the exam itself is perfectly fine. Here we have an example of asymmetrical weight bearing at the start of the exam. So if you see this, and you saw this also on the sensory organization test, it is probably very consistent. If it assuming that all foot placements are correct and as they should be. You would also expect, as you see here, that the response on the weight-bearing limb could be enhanced and that of the unweighted limb will be suppressed. This kind of thing can also be responsible for causing a patient, when balance challenged, to actually spin themselves off to the opposite side, because the left leg here is going to generate maximum force and respond faster than the right leg because it's not as weighted. This patient could actually be, when challenged, spinning themselves off to the side and effectively throwing themselves further off balance. The confidence numbers, as we talked about before, are addressed here. 4s are very good. Because this is a 1, it is abnormal, but all the other scores for the left and right legs for backward movements are also abnormal. I would accept this score. And this also demonstrates very clearly one of the paradoxes that you can see in motor control tests. If you think about the anatomy and physiology of these systems, you can have abnormal scores for one leg in one direction. You can have abnormal scores for both legs in one direction, this case being just backwards. Or you could have abnormal scores in both legs and in both directions. And the more abnormal scores you have, the more you need to move beyond the realm of simple orthopedics and biomechanics and start looking for neuroanatomical and neurophysiological reasons for these abnormal scores. If you have just one leg, one direction, then quite probably you've got an orthopedic issue. A bad knee, a bad ankle, a bad hip. Even both legs in one direction could still be orthopedic. Anytime a motor control test is abnormal, you need to ask yourself the question, is there a biomechanical or musculoskeletal reason for this score being outside the normal limits? If the answer to that is no, then you have evidence to support the presence of neuropathology in that system. You don't know where in that system, but you do have reasons to pursue it further with nerve conduction velocity testings and so on. So here, for example, we have a right leg abnormality only in the forward direction, and the best possible guess here is an orthopedic injury that could be in the lower extremity on the right, possibly spinal and impaired motor, but these are lower in most estimates. If they're prolonged bilaterally in one direction, as I mentioned previously, then you need to look at both lower extremities for possible findings there. Other issues can be pain in the back, and a good musculoskeletal exam would be very necessary. Another recommendation from some people would be to use, for example, tuning fork analysis to look at deep tendon sensation. And if you have both directions and both legs, then quite probably it's peripheral neuropathy. Multiple sclerosis would be something to consider. Again, however, this is not diagnostic specific. You can't look at that data and say that person has multiple sclerosis or brainstem issue or peripheral neuropathy per se. It's telling you that the system itself is not working correctly, that in all probability it's neural of some form, and you need now to go on further with such exams such as the postural evoked response, further diagnostic testing, EMG, NCV type examinations to pull that problem further and further apart. The amplitude scaling is telling you whether or not the patient can generate enough force to maintain balance, or they generate excessive amounts of force in the maintenance of balance. It can be reduced bilaterally in cases where you have lower extremity weakness, somebody who simply is very sedentary individual, they don't put forward, they don't get a lot of exercise, it's a generally inefficient type response. If it's increased bilaterally, then you have other issues that can come into play, antalgia, dysmetria, asymmetry, could be anxiety, they could be sufficiently stressed that they will be over-responsive to these kinds of exams as well. So the question is, does it make physiological sense? And it does. That is a question that does not apply just to the motor control test, but also all the way back to the SOT. Every step of the way is what you're seeing consistent with what you know about physiology and anatomy and neuroanatomy of this patient and what you know about this patient's capabilities. So if no, repeat the exams and compare the results. And if it does make sense, you can proceed with the clinical interpretation. Here we see what would commonly be seen in an aphysiological response. For example, you remember from previous slide on the motor control test how the response itself was present and then it just tailed off into a nice smooth response in the end. You didn't see all of this wild activity coming in. These are all voluntary movements being generated by the patient all the way through here. And this is a common finding in patients with aphysiological performance. Now, a caveat here, you will and can see in some cases these responses ringing almost like they're on a bell. And in that case, that can be a physiological response to patients with excessive muscle contractile problems. So if it's wildly exaggerated and wobbly all over the place, that's one thing. But if it looks more like you just rung a bell and it just oscillates and then dies off, that can be an entirely different finding. There's strong correlations between motor control data and the patient's ability to maintain balance overall. And in some cases with peripheral neuropathy, it does correlate very well. In others, it does not. But the typical situation is you can see abnormal motor control test responses in subclinical cases where the symptoms just have not shown up, particularly in peripheral neuropathies. The last part of computerized dynamic posturography is the adaptation test. And now what we're doing is just simply rotating the platform up or down 8 degrees relatively slowly, 420 degrees per second, looking basically to see what lower limb flexibility, range of motion in the ankles, what that performance looks like. It's very critical in patients at risk for falls. Your older adults, people with bad composite scores, patients with central nervous system diagnoses, or anytime you've got concerns about community level general safety. Those responses, here we have toes up. We do this 5 times. Again, a nice, reasonable response that should damp out, toes down, and the scores should generate relatively even patterns and staying out of the gray zone. Once in a while, you'll get a red bar. This is still within normal limits because overall, this patient is showing an adaptive type of response. Anyone who has problems on the ADT, they're going to have problems with irregular surfaces, sudden inclines, declines. If they complain about when I walk out of my house down the sidewalk and walk across my lawn to water my flowers, I become very unstable walking across my yard. This is an ideal examination for that type of patient. The measurement here is a bit abstract because it's a non-dimensional measure of sway energy that tells you how much force is being generated by the leg, first of all, to dampen the movement. So if your toes are being rotated up, your whole body is being tossed backwards. The first thing you have to do is stop that backward movement. Then you have to turn it around, rebalance yourself, and maintain that balance all the way down to the point where the floor becomes level again or till the floor rises up again. And so here we have very typical results that would be easily within normal limits. Even though there's 1 or 2 points out on these, they're not that far off. It's just a little bit high. There's no fall reactions, no change in sway energy. It's relatively stable. So again, within reason. You compare that to what you would see in somebody who has a severe adaptation problem. Here on the toes up, they fell 5 out of 5 times. They have impaired ankle range of motion. They have some lower limb weakness perhaps. There may be some CNS dysfunction, but you're not sure about that. Here's failure to adapt on the first 2, possibly a little bit of anxiety, a little bit of rehab, a little bit of safety education. They could handle the examination eventually here, so it's not a problem that cannot be resolved. However, total failure to adapt. Here they didn't fall down, but they had generated far too much force on each of these trials. This is a critical type of problem. Again, it's ankle range of motion, lower extremity weakness. A lot of your elderly who spend a lot of time sedentary are going to have issues with this type of examination. It's very critical to know, before we get to the physiological part, whether or not when the patient, for example, has these fall reactions. Let's go back to this one. Did they fall down when the platform was rotating up, or did they fall down when the platform was very slowly returning to baseline? Those are 2 different types of fall reactions. If the patient can handle the very fast rotation up, they noticed that, they adjusted for it, but they lacked the peripheral sensitivity to say that the platform was slowly descending back to baseline, and that's when they fell. So in doing these exams, you need to take note of when that patient fell, at the point of the rotation, either toes up or toes down, or at the point of return of the platform back to the baseline. In terms of patients who show some degree of of exaggeration or unlikely patterns of impaired motor control, look for possible aphysiological responses in these cases. And this can also be very helpful in terms of what the possible prognosis for improvement in these patients is going to be like. In community-dwelling elderly, failing the TOZA adaptation is a very good sign of biomechanical issues and may very well lead to subsequent falls. So what we've done now is we've taken this dynamic model, we've taken it apart into two halves, the sensory and the motor half. We've looked on the sensory side at how we can assess and examine all of the sensory systems feeding into the central nervous system. We've seen how the brain uses that information to determine where the body is in space, what that information can tell us, and then what the motor outflow side of that equation looks like through the motor control test and the adaptation test. So you could see from this how you need to look at balance as a true dynamic process in order to be able to understand it. Because if you only look down a single pathway here, you're not going to get all of the information that you need to resolve that problem. And the critical point is to remember that no one single test stands alone. It's a complete battery, it's a complete picture. And that's what you need to resolve these issues. And that's it. Thank you.
Dr. Peters, thank you for that very thorough and informative presentation. If you would like more information regarding upcoming East archived on-demand presentations, please check onbalance.com off the Neurocom main website. We'd like to thank you for joining this presentation today, and this will conclude our recording.